As I mentioned, sometime in 2015, around then, a few countries, notably Rwanda, who were more, advanced in monitoring resistance, uh, identified the existence of resistant markers. And this was also associated in certain sites with a delay in the clearance of the parasites. So in late failures of drugs. And this has also now been documented in quite a number of other countries, such as Uganda, Eritrea, and Tanzania, also seeing this increase in the markers of resistance. And even other countries in West Africa, Burkina Faso has mentioned the existence of markers, the reduction in the efficacy of some antimalarials and even DRC. So those countries that have invested properly in monitoring this drug resistance are actually able to find and pick up resistant markers, and which is something which, of course, it exists in many places, because when you use drugs, the parasites modify the biological in their genetic composition, and they don't undergo mutations. So this is something which is very expected, but now the thresholds and the prevalence of this mutations and the way they affect the efficacy of the treatments is what is worrisome. And whereas in certain areas, these markers of resistance exist without impacting the treatment efficacy, in a few countries, a couple of countries only, we are actually seeing a decline in the response to treatment of patients. Strategy is actually a very comprehensive document that begins with an assessment, because before you address a situation, you have to understand it. You have to understand the distribution and the extent to which this resistance is presenting in each country. And then you have to document also what are the factors that are driving this resistance. And these may be dependent on the parasite itself, their mutations, their exposure to drugs. They may be dependent on the intensity of transmission. That means certain times when there is low transmission, you see there is the populations have tendency of transmitting. That is, the parasites have a tendency of developing faster because the immunity is lower in these communities. So all these complex issues are those, it's what we call the drivers. And when you identify the drivers, then you can now begin to address them. So one of the ways to address them, which the strategy is very clear on, is first of all, by making sure you understand the gravity, the distribution, and the extent to which the drugs are, there is drug resistance. So surveillance or monitoring the efficacy of drugs, what we call the therapeutic efficacy studies, that countries have to do them very regularly in several sites to make sure that they really understand that the drugs they are using remain effective. Then when they know this, we also have to make sure that if there is resistance, the strategy recommends also that you try to limit the spread of this resistance. And the spread of parasites, the best way to limit it is really to make sure that you cut transmission through vector control. So it's a comprehensive way of addressing resistance. Is really making sure that there is the proper use of vector control, that is insecticide bed nets should be working, and they do not, they prevent that resistant parasite from moving from one person to another. So the use of bed nets or the vector control measures such as insecticide residual spraying is also recommended. And then you want to ensure that you regulate the use of diagnosis and treatment. So most countries have policies that say we have to diagnose before we treat, and most countries have the right drugs that they recommend for their populations, but these are not applied. And this is where we really have a key issue. The national malaria programs, the ministries of health, and the healthcare providers should really seize this see this as a threat and rethink the way they handle their patients and the care, the quality of their care they give. So making sure that each patient is properly diagnosed before getting their treatment. And when they get their treatment, the dosage should be correct. And when you prescribe the drugs, the patient should follow that treatment to the end. There is also a lot of circulation of counterfeit medicines. We also have to look at regulating this circulation of drugs, even in the private sectors, accompany the private sector to have quality assured drugs. So a lot of things to do to enforce regulation so that the diagnostics and treatments are of good quality. And then, of course, if these drugs prove to be resistant, the parasite proves to be resistant to the drugs, then you will think of innovative strategies, innovative ways to use. Either we use the existing tools, so other drugs which we need to bring into our treatment policy guidelines, or we have to, and this is what the global community is doing, trying to innovate by looking for new drugs to replace the ones that are not working anymore.
We are really concerned about antimalarial drugs resistance in Rwanda. And as you know, Rwanda recently documented the pressure resistant to artemisinin. And Rwanda is using AL in the first option, meaning that this is really a threat for us, though the treatment is still working, but we have this pressure resistant to artemisinin. Lumefantrine is still working, but this is a real threat. Key factors we think around this, probably we think of incomplete treatment course. Probably people may be taking drugs for 1 or 2 days, then they stop when they start feeling better. This one assumption. And we also think that through automedication, people can buy low dose of treatment. This may be contributing to drug resistance, but also we may think of cross-border issues, mobile population. People may be moving from other countries, and remember that in other countries, Uganda, Tanzania, Eritrea, many other countries in Africa, and even in Asia, this has been documented. And as people move, probably they are moving with a resistant parasite, but also mosquitoes can transmit resistant parasite from other countries with a cross-border aspect. I think these are key factors we think. And of course, the lack of surveillance when countries do not have a strong surveillance system or do not share data across borders. I think this may be key factors around this. Well, I think as per the WHO guidelines, countries are recommended to combine therapies, and this is what we are doing in Rwanda. We are using ACTs, but of course, if you have this sign of pressure resistance, we should be having other options. Unfortunately, we don't have enough options. This is a threat, but at least combining different treatment options is one of the strategy. Improving access to care, I think, so that people may not be tempted to buy from pharmacies. We need to make sure that people have access to care, but also are educated about why do they need to take drugs for the entire course of prescription. Public awareness is very key, and I think we need to engage community members and ensure that people trying to sell drugs are really found on time, and they put clear measures against this. Strengthening surveillance is very key. And I think as we do therapeutic efficacy studies in Rwanda, we need to make sure that it is done regularly, but also captures key challenges and adapt to the country context. I think sharing data across countries is very key. And currently we are working with different partners under the leadership of MOH and WHO to ensure that at least we introduce multiple phase treatment option as a strategy and to establish a kind of mitigation plan as a national strategic document. These are key areas we are putting more effort, and we think with the collaboration with other countries, we can make it. I think yes, because what we see, it's a national priority. It's within our Ministry of Health priority to make sure that malaria drug resistance is addressed as a whole. We have already established a technical working group for malaria, including WHO and other partners, and we keep it as a priority. We are mobilizing resources from WHO, from other partners and funders, Global Fund, to make sure that we establish a strong surveillance system. And even revising a guideline is one of the priority. I think for us as Rwanda, antimalarial drug resistance receives high attention as for the other antimicrobial resistance as well.
One of those interventions is recommended by WHO, who say that we should be diversifying the first-line drugs that are used. And that makes sense because if all your ACTs are in one basket and one is under threat, the one that's used most often, it makes sense to use more of the other drugs which are available and still very effective. And that does two things. It'll maximize the longevity of the gold standard, which is artemether-lumefantrine. In most countries, that accounts for over 80% of all the ACT used. So it is at risk potentially. And by using alternatives, we can maximize the lifespan of artemether-lumefantrine and also protect the partner drug, which will be used in some of the new generation non-artemisinin products. One way you can diversify ACT use is through an intervention called multiple first-line treatments, or MFT. And that's when you deploy alternative first lines simultaneously, and it makes it harder for the parasites to evolve resistance to a single drug. MMV has supported two large-scale pilots, one in Kenya and one in Burkina Faso, that have looked at the deployment of MFT in practice. And what they've shown is that it can be done from a practical feasibility point of view, and it's also acceptable to both healthcare workers and patients. And we're hoping to support another 13 countries, both in piloting MFT and in deploying at scale through something called the ALARM Partnership, which stands for the African Leadership in ACT Resistance Mitigation. Because this is an African problem, it has to be solved using African individuals, countries, and expertise.
Innovative products come with a premium at the outset. Part of that is the economics of trying to recover in the first few years what R&D might have gone in to the development of products, and part of it's just pure economics of scale. When you are dealing with a mature product that has heavy generic competition and a 15-year track record of scaling up to tens or hundreds of millions of treatments a year, you can bet that competition and the economics of mass production have kicked in to make things very affordable. It takes years sometimes to get that head of steam going for a successful product to become, quote unquote, cheapest chips. as an example, in 2004-ish, when, or even earlier, 2002 probably, when artemether-lumefantrine, the gold standard first ACT, was brought to market by Novartis, they allowed WHO to audit them as an access clause. And WHO sent in Price Waterhouse, I think, and said, based on the cost of you producing this AL, a price of at least $3 would be acceptable. I think Novartis was charging $2.40, and that was considered really scraping bottom. Today, the product is, like Adam was saying, is 65 cents for adults and 20 cents for kids, whatever. So that's thanks to 5 generic companies and hundreds of millions of treatments. At this point, over 1 billion AL treatments have been manufactured and taken. All right, it's a massive thing. When you come in with an innovative product that may aspire to move 1 or 2 million treatments, or maybe just a few 100,000 per treatments per year for the first few years, it's not unusual to see products costing 2 and 3 times as much as today's very genericized AL. And I think once we start accepting that new products in their infancy will be more costly, and then you create frameworks to bring them on the on-ramp, to get them up to speed. Think of it as getting up to speed on a highway. If they can get up to speed, the volume, et cetera, in 2 or 3 or 4 years with guarantees to grow their business, they too can start to become competitive. And so I think what we've really talked about a lot in Geneva with the people who buy these medicines, so the Global Fund, or in Washington, D.C., President's Malaria Initiative, is to say, how do we create a space for premium products to get the boost they need so that within, like I said, a few years, you don't have to worry about the price differences as much. And these mechanisms require you not to throw all the commodities into the same bin and then sift through and chuck out the quote unquote more expensive ones. You'll never build a healthy market if you do that. So, and I've seen this with bed nets, we've seen this with new diagnostics, we've seen it with medicines. You have to create a kind of bubble or protective space to ramp up the new innovative products. Not forever, but for this, fragile time when they're really in their infancy. And I think today there's a greater recognition of the need to create a separate category of funding status for innovative products, at least for this break-in period. But it's not always been easy. And for many of the innovative product manufacturers, I'd say it's been a frustrating journey because they've often gotten just beaten up or driven to the edge of markets because they're not quote unquote price competitive. So on the positive side, I think when Southeast Asia began to get genuinely concerned, and I want to say it's about 2008 or 9, when the evidence came out that the dominant ACT in one of the countries or one of the regions, basically the Thai-Cambodia border, was showing real signs of strain. They did what they had to do without even knowing the exact underlying nature of the marker of resistance. So the Kelch-13 propeller marker had not been isolated yet. And yet they knew that the smartest thing they could do is as early as possible switch. So interestingly, over the course of 2008, 9, 10, 11, 12, they carefully watched drug performance. When they saw declines, they were in an agile mode able to switch. So I think there were at least 2 to 3 switches of the ACTs used in Thailand, Cambodia, particularly those 2 countries, and possibly in the Myanmar border. I don't remember as well. But they showed an agility to move products quickly when they were showing signs of failure. That notion, even though that was a rotational strategy, I think has undergirded some of the logic Adam was alluding to, why multiple first lines. Let's use the soldiers in the best sequence possible. Now, MFT is a concurrent deployment strategy classically. One age band might get drug A and the other age band might get drug B. But rotational was a second best approach. And I think Southeast Asia taught us that if you were serious about it, you paid attention and you reacted, you could help diminish the spread of resistance. Eventually, when they were able to isolate resistance markers, both for artemisinin and partner drugs, then they really took very strategic decisions to completely diminish the use of DHA piperacin. That was the weakest link, and pretty much got it out of the health systems and brought in newer ACTs systematically, like pyronaridine and artesunate, one of the drugs that we helped develop as the last ACTs that were approved. So I think, Mekong showed that if you had action-oriented teams and best deployment of tools, you could do an awful lot. And the science caught up. The science did catch up to help them make smart decisions. Now, where it's not as relevant, and Adam might have touched on this, is, the number of cases in Cambodia at this point in 1 year is sort of like a bad day in Uganda. We're talking 10, 15,000, 20,000 cases per year. That might be Cambodia's current count. Vietnam is below 2,000 cases per year. Thailand is in the hundreds, basically. So those frames of reference are not really applicable to the kind of settings where we're talking about huge geographic spreads across 45 plus countries and 95% of the bulk of malaria burden. So literally hundreds of millions of cases of malaria, at least 200 million cases of malaria in Africa. So the numbers are so dauntingly different than Southeast Asia that it's hard to take 5 or 6 countries in the Mekong and juxtapose that with what Uganda and Rwanda and Ethiopia and Angola and eventually Nigeria and Burkina, those countries have huge burdens to cope with. And their health system ability to turn on a dime, the way we saw some countries do in Southeast Asia, is not comparable at this point. So I think, we have to recognize that there's lessons to be learned, but also very different realities to be juxtaposed.